Let's talk about vascular tumors. Overall, these are not very common, but the common ones are pretty common, and the rare ones are very rare. I've seen a lot of telangiectasias. You see those just about every day in practice, but I've never seen a Kaposi Sarcoma, for example, or a Glomus tumor. So this is a tumor lecture, which means that for most of these questions, they'll just be asking you to make the diagnosis. Not a lot of anatomy, physiology involved, really just playing the match game. Let's talk about the taxonomy of vascular tumors. There's a couple of different schemas we can apply to this knowledge. The first is based on etiology. And vascular tumors can be congenital or they can be acquired. Congenital, you're born with them. Acquired, they develop later in life. And out of acquired vascular tumors, they can be reactive to some other process, or they can be true neoplasms. And out of neoplastic vascular tumors, we can stratify them on aggressiveness. Are they benign or malignant? And another way to look at them is anatomically based on what types of blood vessels they involve, whether they're involving arteries or veins or capillaries or some combination thereof. So let's get started. Let's talk about congenital vascular malformations first, starting with the Salmon Patch. This is a capillary malformation. And when they ask this on the test, they give you a photo of a baby or a kid, and they show you this flat pink macular area that's either on the forehead or it's on the back of the neck, and it's on the midline, and that helps you differentiate it from other things. Because anytime I've seen this asked on a question, it's on the midline. So it's capillary malformation. It's completely benign. If they ask you, what do you want to do about it? Do you want to treat it? The answer is observation. And here's some photos of the Salmon Patch. Those are the two classic locations, back of the neck, in the middle of the forehead. And again, these are flat lesions, and that sets them apart from an infantile hemangioma, which we'll cover later. And that hemangioma has a raised texture and can often present off of midline. So these are flat macular pink lesions. And it makes sense why they ask about these sorts of things because, you know, even though the answer is always observation, parents are often concerned. They want to know what's going on. Is my kid all right? And so you can reassure them, you know, most of the time. Most of these will go away on their own. They'll involute with age. And you can start talking about cosmetic treatment in the form of laser therapy, you know, maybe if somebody gets older. But a watchful waiting approach is usually what's indicated. Now let's talk about port line stains. This is another capillary malformation. Tends to be off midline in a trigeminal nerve distribution. Just a reminder, your trigeminal nerve has ophthalmic and maxillary and mandibular branches, and it's the largest cranial nerve, and those three branches of it just pop off the side of the pons, and these port line stains tend to be in the distribution that nerve supplies. And they tend to be the color of deep red wine, darker than the Salmon Patch, although they're also macular like the Salmon Patch. So here's some photos of the port line stain. Notice that it's off midline a little bit. This one on the left on that baby, that's in the maxillary branch, V2, 5-2 distribution. And these lesions stick with people as they age. The port line stains do not tend to go away, unlike the Salmon Patches. And you can use laser phototherapy to try to get rid of them, but that does not have a great success rate. Maybe about 20% of patients see total resolution of a port line stain after that laser phototherapy. Port line stains can be associated with Sturge-Weber syndrome, and let's talk about that now. I want to make clear that not everybody with a port line stain has Sturge-Weber syndrome, and not even everybody with Sturge-Weber syndrome has a port line stain. Sturge-Weber is pretty rare, and it's got three types, and type 3 Sturge-Weber only has intracranial abnormalities, so in those patients you would not see the dermatologic manifestation of the port line stain. Sturge-Weber is an example of somatic mosaicism. And what that means is that it's not a germline disease. It's not an inheritable disease. It's not something that you get from one of your parents. It's a mutation that happens basically around the blastocyst stage, or maybe when you're a morula. You got 16, 32, 64 cells, something like that. And one of your cells gets a sporadic spontaneous mutation, which is then carried forward, and every cell that grows from that progenitor cell ends up carrying that mutated gene. So when you're a fully grown organism, then only a fraction of your total body is going to carry that genetic mutation, and that's what a somatic mosaic is. So if they ever ask you to identify the somatic mosaic, I think that Sturge-Weber is one that is easier to remember just because the patients present with port wine stain, which is kind of it's a very good picture of somatic mosaicism because only part of the body is affected. But Sturge-Weber is an activating mutation in the GNAQ gene on chromosome 9. And this mutation leads to formation of hemangiomas. So this can be at the skin level, but this can also affect the eyes and the brain. You can get choroidal hemangiomas, which can predispose to visual deficits and glaucoma, even in young children. And you can also get these leptomeningeal hemangiomas, which, if they're in the brain, can cause things like headaches and seizures. So can be a very serious condition. And not necessarily everybody with port wine stain needs an MRI of their head. But if a parent comes in and says, hey, my kid's got this port wine stain in, they talk about getting headaches all the time, or maybe they think they've witnessed an episode of seizure activity, then you should probably get an MRI of the brain in that situation. And if you do get an image of the head, then here's what it classically shows: this train track calcification involving two adjacent gyri. So it looks like rails of the train track. And again, you can kind of see that's a structural abnormality, which is potentially an epileptogenic focus. And another name for Sturge-Weber, this is, getting in the weeds, but it's encephalotrigeminal angiomatosis. So that tells you pretty well what's going on. You're getting growth of blood vessels and an encephalotrigeminal distribution. So it really only affects above the head. Again, these patients can get seizures, and kids who are diagnosed with this need a thorough eye examination. Okay, let's talk about venous malformations. A cavernous hemangioma is something that you usually see in the liver on a test question. I wouldn't say it's common, but I wouldn't say it's rare. And there's definitely a differential diagnosis for liver masses that can include adenoma, focal nodular hyperplasia, hepatocellular carcinoma. So you need to be aware of a cavernous hemangioma because it's on your differential for liver masses. And it's just dilation of usual veins. And so on histology, you see thin walls corresponding with veins. There's no tunica media like an artery would have. And if you see them in the liver, they don't have strong arterial phase enhancement on contrast imaging, whether it's a CT or an MRI. And this will help you tell it apart from something like a hepatocellular carcinoma, which, being a true cancer, it's hypervascular. It's got arterial enhancement, followed by rapid washout. Instead, the characteristic imaging finding with a hemangioma is peripheral nodularity. It's not necessarily pathognomonic, but it's usually diagnostic. If you're ever presented with a liver lesion and they give you imaging characteristics and they say it's got peripheral nodularity, you can probably just click hemangioma and you got the question right. So here's histology of a cavernous hemangioma. We're looking at thin-walled venous structures with, a small amount of connective tissue in between vascular channels. And here's another example. Again, you see glycosaminoglycans, connective tissue, connective cells in between these thin-lined venous vascular channels. And here's an example on gross pathology of a liver with a large cavernous hemangioma. If they're big enough, if they're symptomatic, if they rupture, that would certainly be an indication to go to surgery, but usually you're just observing these patients with serial angle imaging, if that. Okay, arteriovenous malformations. This is when you bypass the capillary bed. So if you bypass the capillary bed, in this case, there is no capillary bed, it's just gone. So you got an artery plugged straight into a vein. So what happens in that situation where blood goes straight from the artery into a venule? So it's going from a high pressure vessel to a low pressure vessel without a significant change in diameter. So this speeds it up. And the image I want you to think of is like a toll booth. You know, like a toll bridge or a toll road. I hate running into them. There's like 1 million of them in Chicago. There's about 2 million of them in Pennsylvania. And you got to carry cash on you, you know, sometimes. It's always just a $20 hit. You never like paying the toll on the toll road. So what would happen if you had a toll road and you took out all the toll booths? Well, you know, you got to slow down, stop at the toll booth. Traffic's backed up sometimes. If you took out all the toll booths, traffic would just go straight forward and you'd get down the road faster. Well, that's what happens with an arteriovenous malformation or fistula. The blood flow speeds up because you skip the capillary bed and you go straight from the artery to the vein. And this is the idea behind surgically created arteriovenous fistulas as well. We do this all the time in end-stage renal disease patients in order to facilitate dialysis. We can make a radiocephalic arteriovenous fistula or a brachiobacillic by sewing the artery and vein together. And by doing this, you speed up blood flow through the vessel and you create a high flow state to facilitate hemodialysis. And the reason why you need a high flow state with dialysis is because you're taking a bunch of concentrated blood full of waste products and pulling the solute out of it and putting it back in the body after it's been filtered and cleaned, replacing kidney function. So when you do this through a peripheral fistula, the high concentration of waste products in the fluid that you're pulling out can cause tissue damage just by diffusion of stuff like urea and other solutes. So that's why you need a high flow vessel for dialysis, is so that the surrounding tissue doesn't get injured by the dialysate fluid you're pulling. And also the speed of the blood flow, the increased speed, can cause a palpable thrill. So if you make a fistula peripherally, say at the wrist, then the way you know your fistula is working properly, has adequate blood flow, is because you can palpate it and you'll feel a vibration. That's what a thrill is. It's just a vibration. And if there is that vibration, it's continuous, then you'll know the fistula is working properly. And this can also help you diagnose an arteriovenous malformation in someone where you've not surgically created a fistula. And unfortunately, people can get arteriovenous malformations in their brain. And that's what it looks like on an MRI. And you probably will not diagnose one of these on physical exam. You'd be the world's best doctor if you did. But these can unfortunately get rather large and involve large territories. Here's girls' pathology from a very large one. And here's what it looks like on histology. We see that there's both arteries and veins involved in this structure. The veins I've circled in blue here and the arteries in red. So if they give you a histologic section and they tell you it's a malformation and you notice there's both arteries and veins present, you're probably looking at an arteriovenous malformation. You can get high output heart failure with one of these, and the mechanism of that is because blood's running through a big fistula and it's pulling preferentially in the venous system. And so preload drops. And so not enough blood's getting back to your heart, and you get a compensatory tachycardia, which over time leads to cardiac remodeling. And this is pretty rare in people with a congenital AVM, but it is something to be aware of in patients where you're creating an arteriovenous fistula, because a lot of those patients are end-stage renal and they don't have the healthiest heart to begin with. So, you know, that additional strain could worsen their heart failure. And you may have to go in there if your fistula is flowing too fast and band it, ligate it, revise it, do something to slow down the volume of blood going through that fistula, so that patients can get better systemic hemodynamics and alleviate heart strain. Now let's talk about cystic hygromas. It's a lymphatic malformation. This one can be a big deal. It's an overgrowth of lymphatic channels, and It's not malignant, it's benign, it's not neoplastic, and it tends to happen in the posterior triangle of the neck or in the axilla. And these tend to be congenital, and about half of them will be present at birth. Rarely adults get them spontaneously. And due to the location of these structures, they can cause airway compression if they're large enough. And as opposed to something like a salmon patch, a cystic hygroma is probably something that should be surgically excised, undoubtedly if it's symptomatic. And if it's asymptomatic at birth, if it's small but still, obvious, then you can talk about delaying surgery until the child has grown up a little bit. Maybe in the 4 to 6 age range would be reasonable. But basically, there's no super rush to do it in some cases, but in other cases there is. It's a case-by-case basis. So here's what they look like. As you can see, they can get very large relative to the newborn child. And there's the classic 2 locations, either at the neck, posterior triangle, or in the axilla. And these are often diagnosed on prenatal ultrasound if they're large enough. Here's an example of an ultrasound showing hypoechoic, cystic, multilobulated structures, kind of right there at the back of the neck, posterolaterally. And you might also see polyhydramnios in one of these patients if there's compression of the esophagus leading to swallowing difficulties. And treatment of large hygromas requires a multidisciplinary approach. You need to be prepared before labor. You need to communicate between the neonatal intensivist, the anesthesia team, and the pediatric surgeon. You need to be ready to intubate if there was concern for airway compromise, or move to a surgical airway, or even if that is not possible due to the location of the hygroma, consider putting these patients on ECMO. And this would be a situation where surgical excision of the hygroma needs to occur as soon as possible after birth, as soon as it's safe to go to surgery. But you don't want to rush. You want to get an MRI to plan treatment of these hygromas. Just to show you landmarks where it is relative to everything deeper down. And sometimes you may decide that it's too risky or too large of a hygroma to just upfront excise, and you may feel that sclerotherapy prior to proceeding with surgery could help in reducing the size of the lesion. And even sclerotherapy can completely eradicate some of these things. So that's also a common treatment modality that we use as an adjunct to surgical excision. And we do intralesional sclerotherapy with bleomycin, a chemotherapeutic, that's an agent. Doxycycline, that's another example of something you just inject into the hygroma cavities itself. Problems are that, again, this tends to be multiloculated, so you may not necessarily hit every single cavity with what you're injecting. You can also give these patients adjuvant sirolimus, or really just wanted to include that just to tell you guys how to pronounce sirolimus or tacrolimus. It's not sirolimus, it's not tacrolimus, it's sirolimus and tacrolimus. And these are basically anti-proliferative medicines, mTOR inhibitors, rapamycin inhibitors. And, pre-treating one of these is basically the same thing as giving neoadjuvant chemotherapy. For a tumor that's, prohibitively large to its size, you want to shrink it down a little bit before you take it out. But eventually you do want to go in and take it out, clear the whole cavity to lower risk of recurrence. Here's what it looks like when you do. You can tell that it's looks like a multiloculated epithelial line cyst. So the differential for one of these includes a branchial cleft cyst, and those tend to be smaller than hygromas, and they tend to form along the anterior border of the sternocleidomastoid as well as at the mandibular angle. Hygromas can appear there too, but they're more commonly posterior in their location. Let's move on to vascular ectasias. The word ectasia means dilation. Two words mean the same thing. And these are normal blood vessels that get dilated for some reason. And they're not true tumors. There's really no hyperplasia. There's no neoplasia going on here. It's just usual vessels that get dilated. Spider angiomas tend to have radial symmetry, and they're secondary to dilation of a central arteriole, which goes on to affect the surrounding capillary branches. And they're linked to cirrhosis because you get increased circulating vascular endothelial growth factor, VEGF, in cirrhosis. And you also get increased peripheral conversion of androgens to estrogens. Estrogen is the slight vasodilator. And then finally, alcohol itself is a vasodilator, and that's the most common cause of cirrhosis. So spider angiomas tend to be focal. You tend to have one or two clustered together. Here's a great example of one. They're focal, not diffuse, and again, they involve arterioles and spread to the surrounding capillaries, but don't involve veins. Here's another example of one on the chest. Again, as you can see, it's just one of them right there. It's rare for them to, people don't have polka dot spider angiomas usually. It's usually just one or two. And if you do suspect some underlying liver disease, you check a complete metabolic panel, make sure you take a good drinking history. But this is the sort of question where usually they're just asking you to make a visual diagnosis. Here's another couple on the nose. Again, these are, you don't always see the, radial symmetry and central arterial. Sometimes they're not as obvious as that. But again, these are two focal lesions, even though they're not classically spider-shaped. And something that can look really similar to spider angiomas, but is different, is a telangiectasia. And telangiectasias are dilated venules. And a lot of different things can predispose to these: age, UV exposure, underlying venous disease, topical steroids. And you can get telangiectasias anywhere on the body, but usually on the legs associated with varicose veins, or on the face. And you can, phototherapy these away for cosmesis if the patient desires, and that's got reasonable treatment success. But these do tend to be, again, very diffuse as opposed to spider angiomas, which is like one here, one there. Telangiectasias can be very widespread. And there's really nothing to do about them. It's just, if a patient wants some sort of cosmetic treatment, you can offer that. But really, there's nothing to do about them. They're not going to turn into anything bad if you just leave them there. Let's talk about Osler-Weber-Rendu Syndrome. This is called hereditary hemorrhagic telangiectasias. You get a lot of telangiectasias when you have Osler-Weber-Rendu. They can be big, they can be friable, they can be bleeding, they can be in atypical locations. And sometimes patients get recurrent nosebleeds. That's a frequent presenting symptom. Also, classically, they will present with GI bleeding. So this would be a question stem of someone who comes in and they've got a positive hemoccult test and they've got anemia on a CBC and they've got spots on their lips or their tongue. And this is what that looks like. This is, again, very classic for Osler-Weber-Rendu. You see telangiectasias on the lips and on the mucosal surface of the tongue as pictured. And usually they're just asking you to make the diagnosis. Or maybe they'll ask you what the inheritance pattern is. And this is an autosomal dominant condition. And just a reminder, autosomal dominant diseases tend to be related to structural abnormalities. So, for example, vasculature or collagen, those tend to be autosomal dominantly inherited, whereas enzyme disorders tend to be autosomal recessive in nature. So, more photos of Osler-Weber-Rendu. Here's an EGD. This is an example of GI bleeding in this condition. We're looking at the stomach using an endoscope, and we're looking from the antrum down distally into the pylorus. And you can tell that the mucosa is friable and red in several areas. And you may initially think that this is gastritis, but if you biopsy one of these areas, it probably would just show you capillary malformations rather than inflammation. So these can bleed. I'm not sure that ablating these is a good idea in everyone who has them. Certainly if it's a clinically significant degree of bleeding, then that's something that we can try. but I probably wouldn't do that routinely. And these capillary malformations can occur anywhere in the GI tract, not just the stomach. They can involve the large intestine, small intestine. You can get arteriovenous kind of malformations in your pancreas, in your liver, with Osler-Weber-Rendu. So it can be difficult to establish a diagnosis because it's just, vague, non-specific GI bleeding to start with usually. And you can get them in the brain too, or in the lungs. Here's an example of an Osler-Weber-Rendu patient with a big telangiectasia in the left lower lobe of the lung. And here's what that would look like on pulmonary angiography. This is a really cool shot. But you can tell that, there's just abnormal filling down there on the left lower side. And finally, don't confuse Osler-Weber-Rendu with Pyogenic syndrome, which also involves the GI tract and also has spots on the lip and also is inherited in an autosomal dominant fashion. With Pyogenic, instead of GI bleeds, you can get GI bleeds, but you get GI polyps, and the polyps bleed in Pyogenic. And polyps tend to be hamartomatous, but you are predisposed to real cancer too, not just hyperplastic hamartomatous polyps. You can get some bad cancers in the GI tract with Pyogenic. And the spots on the lip in this condition are hyperpigmentation. They're not vascular abnormalities. It's just hyperpigmentation, and they look kind of blue. So be able to tell those two conditions apart for boards, maybe not necessarily on this one exam. Moving on, let's talk about reactive vascular hyperplasias. These are acquired. And pyogenic granulomas are usually caused by trauma. And so you get a paper cut on your finger, or you bite your lip too hard or hit it on something, and you end up getting a hypergranulatory response whenever you go to heal. So the analogy here is that it's like a keloid scar, only with a pyogenic granuloma, you got overgrowth of blood vessels rather than laying down too much collagens. But it's the same thing overall as keloid. It's a response to trauma and injury. And so patients tend to be young women, and they like to show you a photo of it on the finger or lip. And I think that when I took this exam, I had that exact same photo for histology. So this is a pretty easy diagnosis. They're very friable because they're hypervascular, same as any hypergranulation tissue. Here's one on the lip. You can get them in atypical spots on the eyelid even. That'd be really bad. But a lot of different treatments. You can put salt on one of these, and sometimes that works. Kind of like putting sugar on a prolapsed ostomy stoma. Or you could just excise it. It may come back if you just use a sharp blade. You could burn it and really coagulate it, or you could try cryoablation. A lot of different things you can try. Okay, Bacillary Angiomatosis. This is from Bartonella, and that's the same bacteria that causes cat scratch fever, which shows up with reactive lymphadenopathy, usually in the axillary neck. Bartonella is a gram-negative aerobe, and it's fastidious, and that means that it takes weeks to grow on a blood agar, so it can be tough to establish the definitive diagnosis. You can see it with a warthin starry stain, and you can treat it with a macrolide or with doxycycline. Immunocompromised patients are prone to infection. People with HIV, for example, are taking steroids or other medicines. You get it from a cat. The cat transmits it to humans, and then it can go from human to human through a body louse. It's a real lousy problem to have. The bacteria causes your cells to make hypoxia-induced factor 1 alpha, which drives VEGF production and ultimately vascular proliferation. And usually that's a good thing. That's why we do cardio, go to the gym. We want to get that VEGF. But here it's limited to the skin. It's not a good thing. It's a problem. So you want to treat it. Again, it's going to be a macrolide or doxycycline. Let's go to some photos. This one is pretty separate, pretty different from other tumors in this lecture. It's raised. It's papular. The patient tends to have a history of an immunocompromised state, and they might mention cat questions to them. So that's vascular angiomatosis. Again, diagnosis is not super difficult. Any questions then? Benign neoplasms. These are true neoplasms, meaning that they have cellular changes, they're hyperproliferative. The infantile hemangioma is one that you do have to differentiate from the salmon patch, from the port wine stain that we talked about earlier. And the way that you do that is probably in the questions, and they'll show you a photo where they'll tell you that this has a raised texture to it. It's got a different topography than surrounding skin. It's not totally flat and macular like the salmon patch or wine stain are. However, similarly to those other two conditions, you just observe this one. You don't do anything about it. You don't cut it out. You don't apply anything topical. You just watch and wait. And most of the time, it involutes and it goes away. I don't have any photos for this because really it's the raised texture. Here's a decent photo of one on the left side. Yeah, you can tell that this is clearly not a macular lesion. You know, there's clearly some texture to it here. Glomus tumor is interesting. Glomangiomas. This is a vascular neoplasm arising from smooth muscle cells of the glomus body, which is involved in peripheral thermoregulation. So it presents with temperature sensitivity, and it tends to present in your fingers where you have a high concentration of thermoreceptors, and it stains positive for smooth muscle actin. So everything about this one makes a lot of sense. They tend to be very small. They all need to be cut out, just about all, you know, if they're symptomatic. They can be under the nail bed, and they can be somewhat hyperpigmented, so you could be concerned for a subungual melanoma. Until you get the tissue pathology back, you really don't know what that tumor under the nail bed is. And let's look at some photos. On histology, you see a bunch of uniform, large, round cells. Looks like a small cell tumor, really. Looks very different than any other tumor covered in this lecture. So if they give you a photo, it should be a diagnosis. But you don't need, it's a clinical diagnosis because, again, these tend to be on the fingers. Here's a good example of one on the side of the finger. Here's a photo of us on the right taking one out. Not us. I didn't do it. You know, somebody did it. Good job. And, you go in and you can do this usually in a minor procedure setting with a good digital block. You just take some local and boom, boom. There's two nerves going, one on each side of the finger. So you hit the inner web space, and then you hit the other inner web space, and then your finger's good and blocked. And the thumb, you got 3 nerves to worry about instead of 2. So you got to hit 3 different points for a good thumb block. But generally, again, this is not something you need to put patient under general anesthesia in order to take out. Sometimes you may have to take the fingernail off. This may be distressing. There's a lot of different people out there. Some people might say, Doc, please put me to sleep for that. Other people might say, hey, can I please watch you take my fingernail off? So patients come in all sorts of shapes and sizes. Here's a cool example of where we're, de-fingernailing finger in order to take out a glomus tumor. And, you can see how you use stay stitches to kind of bend that flap back there so that you can get at the tumor. And that's all I know about this one. I'm not really sure, how the fingernail grows back or what we can do to help it grow back faster or in a more normal anatomical functional state. Just a really interesting tumor with an interesting treatment and easy to remember. Let's talk about Kaposi Sarcoma. This is maybe the one that you could confuse with Bacillary Angiomatosis. But it tends to have a little bit more insidious onset, slower onset. It's not like, boom, you got the infection, you got this rash spreading. It's more so, really slow growth in spots that have been there for, weeks or months. And Kaposi sarcoma is not a true sarcoma. It's a vascular tumor related to herpes virus 8. It's your body's reaction to that viral infection. And you're predisposed to this infection if you're immunocompromised. So the two populations they like to give you solid organ transplant recipients and patients with autoimmune deficiency syndrome. And in the case of the post-transplant patients, usually if you stop their immunosuppression regimen, then you can see improvements in their Kaposi sarcoma. This one tends to involve the trunk I've never read that anywhere. It's just every time I'm seeing a photo of Kaposi sarcoma, it's usually a truncal lesion. Whereas, you know, if we go back and look at Bartonella, remember this is something that you get from a cat scratch. So you're probably going to see, you know, a higher tumor burden in the area immediately around where you got scratched by the cat. If you got scratched on your leg, you'll probably see it on your leg. It'd probably be really weird for you to get it up here on the forehead, you know, out of nowhere, just because that's how bacteria spread. But Kaposi sarcoma can kind of be anywhere, kind of like it's a virus, you know, it's a systemic thing. So it doesn't really have a regional predilection. It's just got the most surface area on your trunk, I think, so it's more likely to present on the trunk. Here's what it looks like grossly. Again, similar to Bacillary Angiomatosis. Raised, papular, maculopapular. These can get really big and bad and ulcerate. And on histology, you see spindle cells, so fibroblasts that are slim. And you see also vascular slits, very slim, thin, narrow vascular channels on histology. So that's Kaposi sarcoma. Oh yeah, they could have a prodrome too. That's something else, you know. Rarely tested, don't think I saw this on boards. Another one that's rarely tested, Epithelioid Hemangioendothelioma. There's only a few hundred cases of this rare disease in the literature, apparently. This is a venous tumor that presents like a superficial or deep venous thrombosis because the tumor starts growing from the wall of a vein into the lumen of the vessel. And this causes at first reflux, but eventually obstruction with edema, pain, thrombophlebitis. So it looks like an SVT or a DVT. So this should be a pretty easy diagnosis. Well, let me walk that statement back. This is probably a very difficult diagnosis to make because you think that your patient has a blood clot. And, you know, 999 times out of 1,000, you'd be right, but because this is a rare tumor. But basically, if you go in and cut out the affected vein, you can see a mass instead of clot. This is a bad problem because it can metastasize and go elsewhere in the body. And it can even prove fatal in some cases. But my teaching point for this specific pathology is let's talk about venous anatomy, okay? You got deep veins and you got superficial veins. What's the difference between them? How do you know if a vein's a deep or a superficial vein? Deep veins are called deep because they sit underneath the muscle fascia. Superficial veins are called superficial because they sit on top of the muscle fascia. You have perforating veins that connect your deep and superficial venous systems. So that's how you should think about venous disease based on anatomy. A deep vein thrombosis is a clot in those veins underneath the muscle fascia. A superficial vein thrombosis is a clot in one of those veins that's outside, superficial to the muscle fascia. We treat SVTs and DVTs differently. So you got to understand your anatomy to make the right diagnosis, to make the right treatment call. Finally, let's talk about angiosarcoma. This is a really bad, highly malignant cancer. And this is one that does show up on boards. I've seen this on a couple of different levels or steps of my boards. And they usually just want you to diagnose it. And classically, it's a patient with a history of radiation. Usually the questions then, the patient has a history of breast cancer or head and neck cancer that they received radiation treatment for. And they can spread hematogenously, and the lungs are the most common site of metastasis. I figure that, if I didn't ask you to make the diagnosis, that would be my next question. How does it metastasize? Unfortunately, this has a poor prognosis. It's difficult to treat. Let's look at some photos. Here's histology of an angiosarcoma. And these are obviously dysplastic cells with swelling and hypergranularity and abnormal architecture. They're not really well connected. This is obviously a bad tumor. Here is a very classic clinical photo of an angiosarcoma at the site of breast radiation following a mastectomy. This is probably the one that's going to be on the test. And here's one on the scalp. They can get really bad. They can ulcerate and bleed. Unfortunately, they can grow pretty quickly too. Real bad disease. So that's it for vascular tumors. Thanks very much if you listen this far. I want to say thank you to Ian Schultz for sending this STL my way. I'm happy to help in any way I can. And good luck to everybody on your exams, and keep studying and working hard.